Thank you everyone for joining us this afternoon for our lunchtime webinar series at St. Joseph's College. We're so delighted to be with you this afternoon to explore understanding Alzheimer's disease. It is our pleasure to introduce Abigail Kaske, class of 2007, social worker for the Stony Brook Center of Excellence for Alzheimer's Disease. And we're very excited to have you with us today, Abigail, not only to share your expertise with our community, but also to provide a valuable resource that's very local to us here on Long Island. So we'd love to hear a little bit more about it, but before we get into it, we just want to give you a few announcements. In the event that you have any questions, which I'm sure you will, because Abigail is going to go over a lot of information, please feel free to ask questions throughout. You can also hold them until another part in the presentation when you feel they might be addressed, or if you just want to hold them a little bit later on in the presentation. Abigail has also uploaded several handouts and resources for you that will be available throughout the webinar. You can feel free to download them anytime. They're in our handout section. And we'll also be sending them as additional resources once the webinar recording is available. Our webinar will be recorded today, so we'll be happy to send that to you at a later date. And we'll also be giving you a survey to take immediately following the webinar. Abigail, thank you so much for joining us, and we're so excited that you're here with us today to talk about such an important topic.
Thank you for having me today, Taryn. I'm really excited to share this information with you all and excited in general to raise awareness about Alzheimer's disease. My hope is that this knowledge will help to combat some ageism and misinformation that's out there so that we all have a base knowledge that Alzheimer's disease is not a part of normal aging. My goal today is to arm you with how to identify early warning signs, help you advocate for dementia screening, and to get access to treatment options. I have personal and both professional experience with this disease, so I understand that it is not an easy task doing this. However, this webinar is designed to help you better navigate the systems that we have in the hope to help you easily get a diagnosis and create a well-rounded treatment team for either you, your loved one, or your patient. So I really appreciate that you've spent the time today with me and joining in. Before I get started, I would like to get a poll of who we have in the audience.
So you're going to go ahead and see that poll on your screen. Go ahead and fill in the answer that you feel best speaks to you. We'll give you about a moment or so to do that, and after you've finished making your choices and everyone's finished, we'll be able to give Abigail the results so she can process those a little bit with you. We'll also have another poll later on in the webinar, so be sure to look out for that. And right now, just finish up and answer that question, whether it's I'm a student, staff, or faculty member. I provide services to patients in this area. I have a personal family-related interest. I'm curious about the topic, or something else that isn't listed here. Okay, we have about 95% of our vote in, waiting for that last vote. Okay, we're going to go ahead and close and share those results with Abigail. So we have 25% say I'm a student, staff, or faculty member at SJC. 17% say I provide services to patients in this area. 50% I have a personal or family-related interest in this topic. 33% I'm curious about the topic and just wanted to learn more, or 8% say something else that isn't listed here.
Great. So thank you for answering the poll. I think we have a good, well-rounded audience today. I hope to meet your needs in terms of learning more about Alzheimer's disease. And let's get started with a general overview with more specifics about what we're going to review today. An overview of dementia with a focus on Alzheimer's disease. We need to know what normal aging is versus dementia in that process. Take a look at assessments, diagnosis, and treatment. Care plans, caregiver support initiatives that are available locally, as well as prevention, clinical trials, and the future, ending on a bit more positive note. A little bit more about our center is that, again, we are the Stony Brook Center of Excellence for Alzheimer's Disease. We're one of 10 grant-funded programs through New York State Department of Health with the goal to raise awareness about Alzheimer's disease and other related dementias, act as a resource to Nassau County and Suffolk County healthcare providers, and provide increased access to screenings, diagnosis and treatment for patients and their families, as well as links to available clinical trials and research studies that are local. So you see our website there. A part of the attachments is our brochure. Feel free to take a look at that and share with either anybody within your community that might need it. Our program is based out of geriatric psychiatry. So we have geriatric psychiatrists on staff, as well as a neuropsychologist and 2 social workers, one being myself, in order to better provide services to help with diagnosis on site, but also to help others make sure that they're using the proper screening tools, and we'll get to that in a little bit. We also offer short-term care management to help link people who receive a diagnosis so they're not kind of left wondering what's next, and they have more awareness and education about the disease process. So let's get started. Understanding these terms is an important foundation for today. So we want to take a look at the continuum of cognition, we'll say. So looking at normal aging, mild cognitive impairment, and that dementia is not a normal part of aging, and understand the terms. Oftentimes, when we're doing presentations and education to providers and the community, people use dementia and Alzheimer's disease interchangeably, and that's not correct. So let's take a look at the terms. So mild cognitive impairment, otherwise known as MCI, is some changes within somebody's cognition. So they're noticing some slight changes. We're not defining it as a dementia process. So there's some changes in maybe their abilities to handle finances, certain activities of daily living are generally preserved. So it's not affecting their functioning as much as dementia does. So looking at dementia, which is the long-term gradual decrease in somebody's ability to think and remember. It's great enough to interfere with their daily life. So somebody's everyday functioning, whether it's from getting up in the morning and picking out what to wear, being able to physically get out of bed, and also handling maybe finances and grocery shopping, things like that. So it's going to interfere with their everyday. And it's a progressive process. So Alzheimer's disease falls under the category of dementia. It's one type of dementia, and it's the most common form of dementia. We believe it's approximately 60 to 80% of those people diagnosed with dementia have Alzheimer's disease. So this is an irreversible form. It's progressive and ultimately a fatal disorder. It's not a part of normal aging. You're going to hear me repeat several things within this webinar, but that's to drive home these points that it's not a part of normal aging, although the number one risk factor is age. So as you age, your likelihood, your chances of getting dementia, specifically Alzheimer's disease type of dementia, increases. Other risk factors also include certain ethnicities. So African Americans and Hispanic populations tend to have higher risk of developing Alzheimer's disease, as well as women, and those who have less education tend to have a higher risk of Alzheimer's disease. We're not quite sure why. Plenty of research is going on right now to learn more about the disease and who's susceptible and why. There is no cure, although a part of this webinar is to teach that there is no cure. However, there are treatment options available. So we want to make sure that people know that if somebody is diagnosed with Alzheimer's disease, that they have options to maintain the best quality of life for them. Getting to the other types of dementia, again, looking at dementia as an umbrella term, there's within it vascular dementia, frontal temporal dementia, Lewy body, and Alzheimer's disease, and many more. It's important to note here that there can be many going on at once. Just like somebody can have a cold and also have diabetes, these don't happen in a vacuum. So somebody could have Alzheimer's disease as well as a vascular type of dementia. And it's important to investigate to know as much about what that diagnosis is for that person in order to help them live their daily life. Also important to know that there are reversible forms of dementia or pseudo-dementias. And that can occur with different vitamin deficiencies, such as B12 deficiency, unmanaged hypothyroidism, some infections in the body, like UTIs, might cause some symptoms that are similar to dementia but are reversible once treated. Hydration and some medication side effects can look like dementia. And again, the irreversible forms of dementia, Alzheimer's disease being the most prevalent, and then the others that we discussed in the earlier slide. So a part of Alzheimer's disease, the major characteristics in the brain are these plaques and tangles. We don't understand as much as we would hope about these at the current state, but we're learning more and more. And what we'd like to review for today is taking a look at where it starts in the brain and seeing how it progresses. So there is a predictable progression within Alzheimer's type of dementia. And these plaques and tangles inhibit the brain's ability to function by communicating cell to cell. So we're not going to go into too deep detail about that because I want to focus more on assessments and making sure that people know where to turn for treatment options. But it's important to understand that within the progression of Alzheimer's disease, that looks different for all people. So although this pattern is predictable from earliest to mild, moderate stages and severe, and has similar symptoms, everybody's progression looks a little different. So on average, we say that people live about 8 years after they are diagnosed. However, some people live up to 20. It's all individualized. If you've met one person with dementia and one person with Alzheimer's type dementia, you've only met one person. Everybody's looks a lot different, and it's important to keep that in mind. So 1 in 2 people know somebody with or somebody affected by Alzheimer's disease. And over 5 million Americans have Alzheimer's disease. It's also a global issue that the World Health Organization has ranked one of the highest issues out there. And its ranking is among the top 10 causes of death. It's currently the number 6 cause of death. However, we believe that it might be higher given the rates are underreported. So every 65 seconds in the U.S., brain in the U.S. develops Alzheimer's disease, and 2/3 of those belong to women. Again, we're not sure why, but we're trying to learn more about that. And reiterating that the number 1 risk factor in whether or not you're more susceptible to Alzheimer's disease is age. 10% of people over 65 are affected, and that jumps to 82% when you look at people aged 75 years or older. Where we come in at our center and the rest of the Centers of Excellence mission is to address that many people are undiagnosed, and we would like to help deal with that issue by offering suggestions for treatment and early diagnosis, pushing people to the doctor's office so that the 50 to 75% of people who are living with dementia and are undiagnosed learn what's going on with them, know that it's not a part of normal aging, and get treatment. A part of this issue is that in an average routine exam, they might appear normal. So unless they have specific screening for dementia, we might not catch some of the early warning signs, and we'll go into that more later. And although many people are undiagnosed, we find that in this survey, 1 in 10 from the CDC reports that they are concerned about their cognition. They believe that there's some sort of change for the worse going on with their cognition. However, more than half of them do not bring it up to their primary provider. Yet, many surveys show that if somebody has dementia, they want to know about that dementia diagnosis. So again, we're here with other allies to help combat that. But before we talk about that diagnosis, we need to take a look at what normal aging looks like. So with cognitive changes that happen in the normal aging brain, it might affect areas of attention, learning, episodic memory, and your cognitive flexibility. So These areas tend to slow with age. So if somebody's saying that they can't multitask anymore, number one, the neuropsychologist on our team would remind us that there is no such thing as multitasking. It's just your brain's ability to switch your attention from one thing to another. And that naturally changes and slows within normal aging. Learning, you can still learn, but in a slower rate. You're less quickly to recall, but you will be able to recall is the important thing to remember. And you're a little bit less flexible with your cognition, so with your thinking and reasoning. However, oftentimes your long-term memory is less affected by age-related decline. And taking a look at the differences between age-related changes, normal, typical age-related issues that might occur versus an early warning sign of Alzheimer's or a different type of dementia. We were looking at memory loss. And so some people will say, oh, I'm forgetting names and appointments, but later on they're able to recall them. That's common versus looking at whether somebody can't hold on to newly learned info. So if that person is repeating themselves often, or maybe even worse, is driving and can't remember how to get home when they lived in that place for 30 some odd years, that's a concern to bring up to your physician, not to let it go as a one-off circumstance, but to make sure to follow up with getting a memory screening. New problems with words or thinking, words and speaking or writing. So sometimes you forget a word, you have trouble remembering what it is. However, if that turns into having trouble identifying an object, such as maybe a watch, and you're calling it a hand clock, or somebody you're noticing that they're doing it more often than not, we want to get that addressed with a professional. Looking at problems with vision and spatial relationships, there are changes in vision with age, so maybe cataracts. You're still going to follow up with a medical professional to deal with that, but you're going to want a specific memory screening if you're having trouble recognizing objects or faces, right? So it's not really where you're putting the keys, but if you're looking at the keys and you recognize what they are and what they do, that's the problem if there's an issue there. Not realizing that you're passing a mirror and maybe you're seeing yourself. So that can be kind of scary to somebody, and maybe they're not going to admit it to you right away. But if you notice some of these changes and somebody shares it with you, urge them to be seen. A decrease or poor judgment. So these are changes. So everybody makes a bad decision once in a while, but if they're getting themselves into financial difficulties, they're more susceptible to those scams that call us every day, several times a day. You want to take note of that, and again, get seen for a screening. Confusion with time or place. So when somebody comes into our office and says, oh, I'm retired, I don't really keep track of what day of the week it is, that's all well and good. I hope that everybody's enjoying their life and not paying attention to whether it's a Sunday or a Monday. That seems like a good life. However, if you are not in tune with which season it is, and maybe the outsiders are seeing that somebody's dressing inappropriate for the weather, you want to dig a little deeper and understand that that could be an early warning sign. Understanding some issues that occur within cognitive decline, we want to make sure that we're addressing it and we're not chalking it up to, again, ageism and assuming that, oh, somebody's old, they're in their 80s, so what do you expect? This is normal aging. No, we want to address that. We want to make sure that people know that those healthy 80, 90-year-olds, they're not outliers. That is what normal aging can look like. And if it doesn't, follow up with your doctor. And then in conversation, somebody can also fool somebody if they're experiencing some changes in their cognition. They can seemingly have great social skills, good sense of humor, intact older memories, because remember, that's not one of the early warning signs. That's not as affected. And so within a general interaction where they have control of the interaction, you're not going to notice it as much versus a clinical assessment, where they'll be able to pick up on some of these early warning signs. And allow that person or patient to answer fully so that you can be the observer and see if some of these changes that we reviewed earlier in speaking and language skills are there. If you're answering for them at doctor's appointments, then you're not allowing the clinician to see what's going on, and also you're not able to recognize it as well. When you get into that office, because you've followed instruction and made sure to advocate for that person and get them tested, the clinician should be checking by using medical tests first, right? We always want to rule out if there's a medical issue going on, referring back to some of those reversible forms of dementia, making sure there's no vitamin deficiencies, so doing blood tests, urine samples, brain imaging, other possible causes, ruling all of them out. And then taking a look at some memory tests to determine that person's baseline cognition. In an ideal world, a part of your annual physical, you would be taking a cognitive exam so that later in life you would be able to compare somebody's normal cognition to whether there's a decline somewhere and be able to catch that quickly. And we like to use the 88 MOCA and mini mental exam. The MOCA and mini mental exam would have to be administered by clinicians. However, the 88, which we'll get to in the next slide, is something that's palpable for the general community. So if you've got some concerns, you want to make them less subjective when you bring it up to the doctor, you can use this 88 to review. We'll go over that in a moment. Also, neuropsychological testing may be recommended. It's a longer exam, and it identifies different areas of the brain and different tasks that may be harder or may be easier for the person. So in identifying areas of changes and areas of decline, that's important to suggest what type of dementia it might be that's occurring, but it's also important because it highlights areas that are still strong for that person. So, and looking at a strengths-based, perspective on treating somebody, knowing that, you might be able to help out in these areas of decline, but allow that person their independence in the areas that they're doing well. And here's more details about the 88 screening tool, which is in the attachment of the webinar. You want to take, again, into account who that person has been. And we're only identifying and saying yes to any of these 8 areas if there's been a change, an abnormal change. So if somebody's kind of always had issues with technology and that's not a change, we're not going to check yes for that. However, 1 yes equals 1 point. If this person, after scoring this and answering these questions, the person would get a 2 or more, you're going to want to bring it up to a doctor and get a more formal screening. A 2 might seem like a very low score in order to trigger a dementia screening. However, we're about early intervention, right? So we don't want to just chalk up any of these changes to just, oh, they had an off day or an off week. No, we want to address some issues that are going on and make sure that there's not an underlying dementia process going on. Understanding that there's no single test that will provide a concrete diagnosis is something that you need to be aware of. However, we take into account not just the exams that I went over, but somebody's thorough medical history, their mental status, again, the history of their mental status, whether they have an outstanding mental health issue and whether that's being treated. We want to know and make sure that that's treated before we assume there's a dementia going on, as well as physical and neurological exams. All of these exams provide more information. The more information we have, the better likely we are to properly identify the correct diagnosis, whether it's Alzheimer's disease or a different form of dementia. And when delivering a diagnosis to somebody, whether it's you as a healthcare professional, or whether it's you receiving it, or you're in the room with that person, these points are really important to take into consideration. So the memory changes are due to a major neurocognitive disorder, right? They're going to affect somebody's thinking process. And I'd like to take it a step further by explaining and stressing to that person that it's a major neurocognitive disorder. It's a medical condition that's affecting your ability to think and function. So it's not them as a person. Many people, because it affects their everyday and their future planning, and kind of their identity, believe it to be a part of their identity. But I think it's very important to distinguish the two, and that that person, because they have a medical issue going on, can't control that they can't find the right word. So explaining that and reinforcing that along the process. It's also important for people to understand that people who have dementia don't necessarily wind up in a nursing home. Reinforcing earlier diagnosis and earlier treatments can help somebody plan, be a part of the planning process, and maintain their independence in the community for a longer amount of time. And I think that's the name of the game, is to get an early diagnosis to maintain somebody's quality of life and their independence for as long as possible. That does not have to mean a nursing home. Eventually, we want to be honest about dementia not having a cure right now, and that it will eventually worsen the person's ability to function with such tasks as shopping and finances and medication, but to have a regular conversation with your treatment team about that and your support to manage that before any of those areas become an issue. Often people think that, oh, it runs in the family. Typically, dementia is not hereditary in most cases. We believe about 5% of cases with Alzheimer's disease are hereditary. That's a pretty low statistic. So it doesn't necessarily mean if somebody has dementia in your family that you're going to get it. Dementia is a progressive condition with no cure, but we have treatments for the symptoms. We'll get into a little bit more about that later on. But letting that person know that although there's no cure, there are treatments for symptoms. And proper care and planning can greatly alleviate the burden. It's not going to take everything away, but hopefully create some more clarity on where to go and how to plan, and more moments to spend however you choose to. Lastly, important for you and your family to plan for the future. So I've been reiterating this throughout this slide and others. But again, early intervention, early diagnosis, it allows you more time to be involved in the planning process, and especially making important legal decisions. The medication, in the interest of time, we've included this breakdown of the different medications. It's on the NIH website, and you can also order them for free. But they do a really good job of breaking down the different available medications for dementia and memory loss, and the differences between them. So I would recommend taking a look at this handout. And it's, again, important to know that they don't slow or stop the damage that's going on in the brain, but they can temporarily improve the symptoms. And right now, the name of the game, again, taking care of that person to maintain their independence for as long as possible, and create a good quality of life at whatever stage they're in.
Abigail, I just want to mention we have a question from Mary in the audience. It says, is someone who had brain trauma, in parentheses, an aneurysm, more prone to Alzheimer's?
So, yes, in a way. So they're more prone, they have a greater risk factor of developing a type of dementia. That might be more vascular dementia because they're dealing with more issues on that end. So I would say yes, there are many different risk factors involved, cardiovascular health being one of them, and we'll get to kind of more prevention and how to prevent that too, or even help somebody within that circumstance. So I hope that answered your question. Considerations for care management. Again, earlier intervention, earlier understanding about the disease process, leading to your ability to hit all these check boxes, right? Making sure to, almost one of the first things, legal planning, financial planning, making sure that you're setting up your future as best you can. We don't have control over everything, but we'd like to plan, and that planning can go a long way in not only for yourself, making sure that your needs, your wants are known, but to avoid any maybe family conflicts or lessen the likelihood of some family conflicts because you've already stated your wishes and set the ground rules for what the plan is. Interdisciplinary community support, making sure that you build your team, whether that's people around you in your community that are available to support you in different ways and different roles, and medical professionals, making sure that your primary care doctor is speaking with the neurologist and whoever else is involved, maybe the geriatric psychiatrist, making sure that they're communicating so they're taking care of the full person. Caregiver stress. Caregivers, it's an understatement to say that they do a lot and they carry a lot of burden. They, in addition to the other roles in their life, have the job of caring for their loved one who may or may not have dementia. And we know that studies find if you take care of the caregiver, it improves the outcome for the patient. For dementia patients, that outcome is not going to be a cure, but again, it's about getting a better quality of life for these people, both caregiver and the patient. So we'll go into some initiatives and resources a bit later on. Medications, for the interest of time, please review the attachment and behavioral issues and behavioral approaches. I work within the Center of Excellence Clinic, and we're based out of geriatric psychiatry. So we offer people the option of psychotropic medication to help with their mood, their anxiety, other symptoms that may arise. And that's not with the intent of kind of medicating people who have dementia. It's, again, making sure that they are given options to improve their quality of life, maybe medications to help them with depression and anxiety that can help them get over the hump of maybe getting out of the house, socializing, because that's going to help improve their condition, as well as exercising. So giving people the options, and also behavioral approaches that we'll review a little later on. Safety, driving is a huge one that comes up, aside from also wandering, but driving, whether or not to take away the keys, when to have that conversation, and helping that person and the caregiver have that conversation. When somebody gets the diagnosis, we suggest that they have an adaptive driving test to see where they fall, whether they are a safe driver. Again, if they're very early in the disease process, we don't want to strip them of all their independence. And on Long Island and many other places, driving is a big piece of our independence. So if they're safe, it might not be necessary to have that conversation right. Well, you can start the conversation, but not take away the keys just yet. And for legal purposes, liability purposes, it's good to have that test and documentation saying, no, the person's safe right now. But returning to that later on. Elder abuse, being aware of the different types of elder abuse that can be out there and knowing if you spot it, to address it. The neglect, verbal, financial, and physical. Aging in place versus long-term placement. Again, making sure that that person has the options available to them. If their goal is to age in place, they have that option. But we usually suggest that people take a look at it all and use safety as a barometer, whether or not it's safe to keep that person maintained in the community. If it is, great, let's get some more supports in-house. If they're doing well at home, still understanding the options for long-term care and putting yourself on a wait list if you need to, just in case an issue occurs where it's not safe for the person to be in the community. Palliative care, taking care of the symptoms of a terminal disease, making sure that that person is cared for regardless of whether or not the disease is curable. It's not always a conversation had within dementia care, but it's slowly but surely becoming one. And making sure that things that are kind of assumed as along the way, a part of the disease process, are still treated. For example, later on in the disease process, somebody's going to have problems with swallowing, not just saying, oh, well, that's a part of it. Studies have shown that different music therapies, individualized music for that person, played for that person 20 to 15 minutes prior to them eating, actually improves their ability to eat and swallow and lessens the instances of choking. So again, paying attention to the symptoms, whether or not they're common in the disease, and making a plan to help that person with it. And of course, clinical trials and referrals for the patient and even healthy family members. More on that later. Behavioral approaches. This goes back to knowing and keeping in mind who that person is or was in your mind. What were their meaningful activities beforehand, their hobbies, making that possible and changing it so that it's appropriate for them wherever they fall with their cognition at the moment. So I've worked with some family members who have been really creative in making sure their loved one is engaged in meaningful activity. And so some of that means, engaging at the library, different events that they have going on, senior services that are available, social model programs, as well as I know somebody who was a carpenter. They worked with wood, but it was no longer appropriate for them to be handling heavy machinery. So the family was able to buy kits to put together that were already pre-cut, but that person was still able to have the satisfaction of putting something together. So making those moments possible for the person. And that can also help ease anxiety and agitation. So that person feels kind of rewarded for doing what they love to do, and also for anxiety and agitation, including individualized music for that person. So you find that the music that's most beneficial is from the age of 13 to 14 for that person. So if you're able to tap into what they were interested in then, that's going to help with their mood more so than maybe just throwing on classical music if they weren't interested in that to begin with. Dance, supportive counseling, massage, who doesn't love that? Reminiscence therapy, again, going back to what that person enjoyed, and that they still may enjoy it, just in a different level. Looking at environmental design and modification, sometimes physical therapy and occupational therapy services that come in homes can kind of do that for you and put you in the right direction as to what you should be changing. That doesn't have to fall on you, the caregiver, or the person. So reaching out for help there. And general problem solving and management planning. So not trying to recreate the wheel, the Alzheimer's Association of LA has done a great job in providing standardized care plans for all of these issues that might occur with Alzheimer's disease patients or any other dementia patients. Some people don't realize that issues such as hallucinations can happen. So these care plans and identifying them can help normalize this issue, that it might be a symptom that occurs within this disease process. And so it helps kind of guide the person in learning about different ways to handle it. Again, it's easier said than done. I want to acknowledge that, but it's helpful to kind of have a plan that's worked for other people and modify that where you see fit. So I urge you to go to the website at the bottom for more information. One of the approaches used is the IDEA approach, and applying this to many different issues that might occur. So a common one is wandering. Using the IDEA approach, you're going to identify the problem, which would be wandering, and they want to reduce it without medication. So the family or caregiver, whoever that might be, is going to educate yourself about the triggers. What's going on? What does it mean for the person, and meaning for the caregiver? So a general awareness about what's going on at the moment that they are wandering. So if it's in the middle of the night, are they disoriented to the time? Do they think that they're going to work because they've kind of regressed to that stage in their life, and that would be maybe the meaning for that person, and that they're a little confused and they're worried that they're going to be late. Then meaning for the caregiver, it's 2 a.m., the person's trying to leave the house, you're going to be frustrated. Acknowledging that and allowing yourself to be a little annoyed about the situation, but making sure that you have your toolkit and who you can utilize in that event to keep that person safe. So going to the adapting part of the approach, being prepared, having medical alerts, hiding the coats and the keys, understanding kind of making sure that the environment is prepped as much as possible in advance to this reoccurring issue. And maybe exercising, making sure the person exercises so they're a little less restless if that's a part of a cause. Home safety, childproof locks, gates, bells in the door, and also distract. So again, if we're going back to the person thinking that they are going to work, distracting them using positive words. Regardless of what stage this person is in within this disease process, they might not be able to identify who you are or what certain objects are. However, they will still be able to know the mood in the room. Then they're going to respond to that. So you want to make sure to be as positive as possible. We understand that you're going to be stressed out maybe, if you lack sleep in that situation, but preparing ahead of time, maybe with a plan of saying, oh, you never go to work without a cup of coffee or without breakfast, and having something quick to distract them, get them to sit at the table, try to have a conversation with them, and hopefully distract them enough to let go of the wanting to leave the house. Again, easier said than done, but the approach can be applied to many different issues within dementia. And the New York Times had a great article that although dementia doesn't improve, many patients can still learn, and they took a look at cognitive rehabilitation. So with occupational therapists, and this is one of the attachments for the webinar, this looked at occupational therapists coming in the home to help treat dementia patients and address issues of activities that they were struggling with. The important thing to acknowledge here is that the person and caregiver identified these issues, these tasks as important. So you're already getting the buy-in from the patient that this is something that they want to maintain their independence in. So that could be organizing a visit with a friend, keeping track of the day's appointments and plans, again, having some sort of control over their daily life. Heating and preparing lunch without burning it, so making sure to, prepare a meal for yourself. And so over weekly sessions, over several months, the therapists were able to make individualized plans, and that was able to help the person compensate for some of the memory problems and to utilize new techniques. So again, not all hope is lost. Somebody can maintain their independence for a longer amount of time. It doesn't reverse the effects of dementia or stop it, but again, it's a therapy that can help them maintain their independence for longer. And also found to lessen the likelihood of them being institutionalized. So going into a hospital setting or an inpatient setting. And again, that's keeping somebody independent as well. So keeping that in mind as an option. When I'm trying to refer somebody for occupational therapy in an earlier stage, we often get the response of, oh, well, I'm not there yet. The point of these therapies is to get involved in it before you're there where everybody knows that you need help and you've reached the critical moment. The earlier you get some interventions, the more time you have to maintain that independence. And I can't not review some social work principles and techniques, given I'm a social worker, a part of this team. So first and foremost, education. You're already doing that by attending this webinar, so thank you again. But again, educating yourself, educating the family members, the patient about the disease process, and not for it to be a depressing educational experience because it's a progressive and fatal disorder, but arming them with the knowledge of what may happen and how they can handle it. Self-determination, a term talking to the person's ability to kind of make decisions for themselves. So making sure that if they have an earlier diagnosis, again, they're more involved in their planning and can say what they want to happen. Again, if they're involved in earlier treatments too, they can maintain their independence for longer, be able to communicate for longer, and maybe do some tasks that they want to do, improving and maintaining their self-determination. Grief counseling, that could be a whole webinar within of itself. Making sure that not only you're acknowledging the grief counseling for the loved ones and the patient, but that you know that it's a process that starts and it's a long one for everybody involved. And that looks different for everybody. It can also, awareness of the grief process cannot alleviate all conflicts within families and the loved one with family members, but it can help to gain better understanding of where that person's at, and that maybe how they're acting isn't a response to this person, it's a response to how they're grieving this situation.
Abigail,
yeah.
There's a question from the audience that says, so initially the person may be aware of having dementia, but as it progresses, are they still aware of their problem and just can't verbalize it?
So because it affects different areas of their brain, it will be affecting their reasoning, right? We talked about the poor judgment and reasoning piece. and that limits their insight, so their awareness of them having this disorder. So earlier on, yes, you'll be able to have more of a conversation with them. Later on, and we're kind of jumping ahead within this slide, you could use kind of more therapeutic lying tools, techniques, to help to engage them in conversation and get them to do some of the tasks that are beneficial to their health, if that answers the question. So yes, they'll have less insight into their disease. It's a part of this disease process, it affecting their judgment, but there's ways around that. And it's the education piece for those around that patient that help make it an easier transition to get them to do other tasks without reiterating reality, which is that you have dementia, right? That's not our job here. Our job is to treat the person at whatever stage they're at. And if they're at the stage where they're not aware that they have the disease, well, we don't need to remind them. We can work with them using therapeutic lying and entering into their reality to creatively get them to do whatever it is we're looking at, eat, engage in maybe a day program. I've heard some people say that, the day programs worked with them to act as if like that's work for that person, and other things like go to doctor's appointments.
Abigail, one more question. Mark wants to know, is an older person who becomes a worrier a sign of dementia?
I would need to know more information about that. Somebody that shows me that they have maybe increase in anxiety and concern in general, and you'd want to give them a little bit more attention and gain more information about what's going on for that person to determine whether or not it's a dementia process or if there's a lot of changes that's going on in their life, and then that's creating some more anxiety and fear and worry. So I can't say a definite yes for that, but I would say to check in with them, learn a little bit more to see if there's some more warning signs. Getting back to some of the techniques, motivational interviewing is a technique used by a lot of counselors, social workers, mental health professionals in engaging the person in stages of change, helping getting that person to change. And so in the earlier process, you might use some of these techniques to get that person in on the earlier end of the dementia disease or the Alzheimer's disease, when they have a little bit more awareness of what's going on, to get them to an appointment. And also using this to help the family members learn more about the disease and understand that they might have to be changing their behavior to get a better outcome. Therapeutic lying we kind of went into with that question, so thank you for that. And advocacy, so at a micro and macro level, making sure that maybe you're advocating to get that person in for a screening. Maybe you're making sure that you're advocating to the insurance company that they need that brain imaging test, and advocating for more programs to support these individuals in different legislation that help to create more awareness about Alzheimer's disease in general. So we want to do a quick poll now, talking about who you are in relation to this whole disease process, whether you're a caregiver, and so I'm going to hand it over to Karen for that.
So you should all now see the poll on your screen. Do you consider yourself a caregiver? You can check all that apply. It says yes, maybe, I'm not sure, no, not now, but I have been in the past, not yet, but I may be taking on that role in the future. So again, you can choose more than one. If you feel there's more than one that speaks to you or has spoken to you at one point, go ahead and select your choices, and we'll go ahead and go over them in a second. So again, do you consider yourself a caregiver? Yes, maybe, I'm not sure, no, not now, but I've been in the past, and not yet, but I may be taking on that role in the future. Okay, we're going to go ahead and close that poll and show our results. So it's showing 31% say yes, I consider myself a caregiver. 8% say maybe / I'm not sure. 31% say no, 23% say not now, but I have been in the past, and an interesting 38%, the largest percentage, says not yet, but I may be taking on that role in the future. Abigail, I feel like that feedback is really important for us right now.
Yeah, so I think that it's important to identify then some of the stats about caregivers, and that, there are, most likely, if you've not identified yourself as a caregiver right now, you probably have been. And if you're thinking that you might be one in the future, feel free. That tells me that there's some concerns about somebody that is within your family or community that you're concerned about. So feel free to call us, and we'll help kind of troubleshoot some issues. Oftentimes there are people that call our center with some questions about whether or not they should bring somebody in or advocate to their own doctor about what's going on, and then how to get that person motivated into an appointment. So I'd offer that to all of you. And, looking at the numbers for caregivers, for each affected person by Alzheimer's disease, there's 3 family or caregivers that provide unpaid for help. So that's $232 billion, most of which are women. So I'm going to try to unfortunately breeze through some of this because I know we don't have all that much time. But it's important to realize that a third are actually in the senior population themselves. Half are primary caretakers of children for parents, and a third live with the 2/3 live with the individual, and a fourth are that sandwich generation that we talk about that are caring for their loved one, their older adult as well as child. Elements of caregiving, what they do. These are some examples. I'm sure there's a much longer list that we could provide, but this is some of what we look at as caregiving. And what I want you to take home, one of the many things, are these caregiver support initiatives that are available, many of which provide free services. So they provide social groups for the caregiver, individual therapy sometimes in-home free consultation. The 24/7 helpline from Alzheimer's Association can be utilized as a resource, and also kind of a crisis line to some degree, since they're open always and you get a master's level healthcare professional answering the phone. Drop down to Office of the Aging. Whether you're local or whether you're from Long Island, I would urge you to reach out to your Office of the Aging and make sure that you're aware of the different services, including respite. Sometimes there's events going on that the caregiver feels that it's inappropriate to bring the patient, but they want to attend. We want them to be involved in their social life, whether it's friends or family, maybe a wedding. So maybe getting on the list, making sure they're aware of some respite services so that they can engage in their life, as well as making sure that their loved one is cared for. I'm going to breeze through some of the prevention, but take note that there are many different modifiable factors, all of which listed here, that you want to address. There's about 65% of the factors that are not in your control, that if they're not in your control, you can't do anything about it, to lessen your likelihood of getting dementia, Alzheimer's disease dementia. So what you can do is focus on the potentially modifiable factors, which contribute to 35% lowering your risk of getting Alzheimer's disease. The number one is hearing loss. So addressing that, making sure that you're still engaged, you're able to speak with people, and you're not losing kind of that faculty. So hopefully these slides will be available so you can go in more detail. And the quick message for prevention is what's good for your general health is also good for your brain health. And that means exercise. You may or may not be happy hearing that, but I hope that this motivates you to get moving and make sure to incorporate some sort of exercise in your daily living, because that improves your brain cognitive reserve, reduces brain damage, and reduces inflammation in the brain, as well as, being social, and diet and exercise. So this just goes into how inflammation helps to increase, decreasing inflammation using exercise can help increase your brain health. Again, exercise as treatment. This has been found to be just as effective, if not more effective, than some of the medications we have out there for mild cognitive impairment that's stage before dementia, but not quite normal aging, and Alzheimer's disease earlier on. So again, get moving. And diet and exercise. So diet, part of it, focusing on maybe the Mediterranean diet or the DAX diet, looking at those healthy fats, more fruits and vegetables, less processed foods, red meat. Again, taking care of your body without all those added sugars and things. So you can feel free to research more on that and change so you've got less likelihood of a cognitive decline. And more studies that, again, show that these healthy fats help improve your overall cognition. So extra virgin olive oil and mixed nuts. For memory, frontal cognition, so kind of the judgment piece and just in general. And when you combine the two, diet and exercise with some cognitive training and vascular risk factors are controlled, it's overall improved cognition. If you want more information, I would suggest Googling finger study, and they've got more information about what that cognitive training means and the specifics on the diet and exercise piece. In the future, we're looking to do more studies to learn more about this disease. Although it's been around for a century, we still don't have a cure. We still don't have any survivors, and so we want to try to treat the disease where it starts. And in order to do that, we need more biomarkers so that we're able to properly identify it. So looking at biomarkers in the blood, spinal fluid, or brain imaging, and allowing, again, earlier, more accurate diagnosis. Importance of clinical trials. You can feel free to take a look at this article at the link below. But it does a good job in outlining why it's so important to engage in clinical trials if you're so inclined, and hopefully you are, because the math is not good. There's over 100 Alzheimer's studies, and in order to reach the recruitment, the goal for recruitment, they've got to do outreach to 37.5 million within the appropriate age group. And then 10 of which are referred to a trial site for a screening. Only 4% actually receive the evaluation, and with the dropout rate and screening failure rate, that finally leaves the goal amount of participants. But this is no easy task. And again, they're looking for people in the earlier stages, mild cognitive impairment, not quite developed dementia, and also at the earlier stages of dementia, whether it's Alzheimer's disease or other types. Again, the research, even though we've not been successful in finding a cure, it's important to note that we have been successful with treatment options, with medication for symptoms, improved quality of life interventions, which we reviewed, and prevention. And here are different sites that you can go to if you're interested in getting involved in a clinical trial. Thank you so much for your time. Feel free to let me know if you have any questions at this moment. I would love to answer them, whether here in the webinar or over the phone if you wanted to call our center.
Abigail, thank you so much for that amazing webinar. We do have some questions, and we invite our audience to keep these questions coming. They're amazing, and I'm sure you're not the only person that has this on your mind from those of us joining today. Someone would like to know, is there a chance of dementia becoming irreversible if a patient suffers from constant UTIs?
So I don't think that's the case. I'd be more concerned if somebody suffers from constant UTIs that there's already a dementia process going on, because they're not tending to maybe clean themselves appropriately. And so that might be a warning sign that they're not taking care of, their activities of daily living that we talked about in the beginning. And there might already be something happening that nobody's taking a look at because we're just treating the UTI. I hope that answers your question. So I wouldn't say that reoccurring UTIs would cause or increase the risk. I would say that the reoccurring UTI would kind of be a risk factor or an early warning sign that they're not taking care of themselves, and we want to know why is that.
We have a comment from Mary. Mary says, excellent presentation. Thank you.
Thank you so much. I appreciate everybody's time and joining us today.
Abigail, last question for you today. For those of us who might be on the call thinking about a concerned family member or somebody they might be concerned about, now they have a lot of information. What would you suggest would be the next step for someone in that situation?
If somebody's concerned, I would say go to your primary care physician. We want to make sure that they're aware of the issue and give them the opportunity to address it. And certainly you can call again our center to gain more information and more guidance on that. But we definitely, hopefully you have or they have a primary care physician, and you can specifically ask them, use that 88 tool that is a part of the handout, complete it and say, listen, these are my concerns. And you can say that you listened to this webinar and you got more information, and this is what's brought you in today, as well as the 88 not looking so great. And then if you're getting the answer and they're referring you to more of a specialist, great. You can certainly come to our center for a consultative visit. We're usually able to get people within like a month, 2 months for a consult visit, and we can offer suggestions of a care plan for that diagnosis, help you get a diagnosis and offer it back to your primary care physician. But we want to give them the opportunity to investigate further and offer you any resources that they're aware of too. And if you get an answer that says, no, they seem to be fine, I wouldn't stop there. You know the person best, most likely. The more you're around them, more than the clinician, and they're all meeting well. But don't stop there. Make sure that you're following up and getting more answers.
We actually have a last-minute question. One more question from Mark. It says, can constant kidney issues due to the lack of drinking water cause memory issues?
Not that I'm aware of, but it's the lack of drinking water. Was that the question?
Yes, the lack of I think it's constant kidney issues due to the lack of drinking water. I think it's saying, can that cause memory issues?
So that's going to be a sign that there are other medical issues going on within the body. And again, going back to getting more information, getting more medical tests to rule out other medical issues that could be affecting cognition versus a cognitive neurocognitive, major neurocognitive brain disorder happening, causing, the other way around. So we want to make sure to get more information about the medical condition instead of assuming that that might be leading to a dementia. I hope that answers your question. But ultimately, the guidelines for following up would be, again, to get any medical conditions under wraps and treat it. Also mental health, and then looking at the cognition and what the baseline cognition is there. And if it's still not good when you're treating their mental and physical health, then we're going to go to looking at whether it's a dementia process.
Abigail, a comment from Rebecca. It says, thank you. This was so educational.
You're welcome.
Thank you, everyone, for joining us today. You will see a survey immediately pop up on your screen right after this webinar. We'll also be sending you the survey tomorrow as well. Once the slides are available and up on our website, we will absolutely send you the link where you can access them. We will also be following up and sending you the additional 5 resources that Abigail provided in the webinar as well. Thank you, all of us, for joining us this afternoon. On behalf of St. Joseph's College, on behalf of the Office of Alumni Engagement, I'd just like to thank you so much, Abigail, for joining us today, for sharing not only your expertise, but just a much needed resource for all of us in the community. Thank you so much.
Thank you.
Thank you, everyone. Have a great rest of your day.